be having a clinical case presentation. The case theme would be rheumatic heart disease. So we'll be having the presenter from VMMC and Safdarjung Hospital, New Delhi, Dr. Abhinav Agarwal. And would like to have experts, Professor Nitish Nayak, Professor Ranjit Nath, Professor Girish MP, and Samir Srivastava sir. And of course, we have Hariharan sir and Professor Sandeep Seth. So without much delay, we'll call the presenter for case presentation. Case details, just put one here and then read this.
Good afternoon, respected teachers. Yes, I'm presenting the case of Mrs. S, who's a 28-year-old female resident of Kasganj in UP, housewife, and she's illiterate. Her presenting complaints was she presented to us with complaint of dyspnea on exertion for the past 2.5 years, increased for the past 6 months, and exertional chest pain for past 1 year, increased for past 6 months, and exertional palpitations for the past 1 year, increased for 6 months. Coming to the history of presenting illness, she was apparently well 2.5 years ago when she developed dyspnea on exertion, which was insidious in onset and gradually progressive. Initially, she had dyspnea on going to her farms, which were around 1.5 kilometers away from her house, and on climbing 2 to 3 flights of stairs. But gradually, over a period of the past 6 months, the dyspnea has progressed to a level when it occurs even on doing routine household activities and on climbing 1 flight of stairs. The dyspnea is relieved at rest, and there is no history of orthopnea. There is also history of 2 nocturnal episodes of breathlessness 6 months ago, which occurred around 2 hours after going to sleep, for which the patient had to get up and rush to the window, gasping for air with breathlessness, and this was relieved 15 to 20 minutes after assuming an upright posture. The dyspnea is not associated with any cough or hemoptysis. She was pregnant with period of gestation 16 weeks, 2.5 years ago, when she perceived the dyspnea on exertion, and she had the exacerbation of the dyspnea at the time of delivery, for which she was treated in a local hospital. She was advised to go to higher center for further evaluation after discharge, but the advice was not followed. She also complained of exertional chest pain for the past 1 year, which has progressed for the past 6 months in a manner similar to the dyspnea. The pain was retrosternal, occurred only on exertion, was constricting in nature, non-radiating, and associated with dyspnea, and was relieved on rest. There was no history of any diurnal variation of the chest pain. She also complained of exertional palpitations for the past 1 year, which have been regular and rapid, gradual in onset and offset, associated with forceful precordial activity, and occurred only on exertion and never at rest. The palpitation progressed in a manner similar to the exertional chest pain from NYHA class 2 to 3 over a period of 6 months. The palpitations were not associated with any post palpitation diuresis or loss of consciousness. There was no history of syncope, cough with hemoptysis, swelling in lower limbs, loss of appetite, abdominal distension, nausea or vomiting, no history of hoarseness of voice or difficulty in swallowing, no history of any skin lesions, joint pain or sore throat in the past, no history of limb weakness, altered sensorium, slurring of speech, or diminution of vision, no history of any menorrhagia, excessive bleeding from any site, or blood in stools. Obstetric history. She is married for the past 6 years and has 3 children. The oldest daughter is 5 years old, the second daughter is 4 years old, and the youngest son is 2 years old. All were full term normal vaginal delivery in the hospital. And she developed the dyspnea during the pregnancy 2.5 years ago in the second trimester when she was pregnant with her last child, who is the youngest son. and she has normal and regular menstruation. Treatment history. 6 months ago, she consulted a government hospital for exacerbation of her symptoms, where she was told to have some cardiac disease and was prescribed an IM injection every 21 days and some diuretics, after which her symptoms improved. And there is no past history of hypertension, diabetes, tuberculosis, or any significant disease in the past. In personal history, she is non-alcoholic, non-smoker, vegetarian, and has normal bowel bladder and sleep pattern. And there is no significant family history of similar illness or any cardiac disease in the past. Socioeconomic history, she belongs to lower middle class according to the modified Kupuswamy scale. So, summarizing my history, my patient is a 28-year-old female who presented with complaints of insidious onset, gradually progressive dyspnea on exertion for the past 2.5 years, and has progressed from NYHA class 2 to NYHA class 3 over a period of past 6 months, with the onset of symptom first noticed during second trimester of the pregnancy, with history of exacerbation of symptoms occurring at the time of delivery. And she also has complaints of exertional chest pain for past 1 year, progressed from NYHA class 2 to 3 over a period of 6 months, and exertional volume overload type of regular palpitations for the past 1 year, also increased over a period of 6 months from NYHA class 2 to class 3.
Any previous history of rheumatic fever during childhood?
No, sir, no history of rheumatic fever.
That you should mention if you are presenting such type of history.
No.
You should mention either it is whether it is present or not. You should mention that.
One more omission was probably the delivery. So, what kind of delivery? Institutional,
Full-term normal vaginal.
normal vaginal
Yes.
delivery. Any deterioration of symptoms during that?
She had deterioration of symptoms for which she was treated in the local hospital. However, it was not evaluated in detail at that time. She was advised to consult higher center for that. However, the symptoms relieved a few weeks after delivery, and after that she did not consult anyone.
So, what is the physiological basis of your or functional basis of your symptoms? So, these symptoms of dyspnea,
Yes,
the
sir.
chest pain, and palpitations. Okay, so what is the physiological explanation for these things?
So the dyspnea that the patient has is likely because of pulmonary venous hypertension, because it is also associated with 2 episodes of paroxysmal nocturnal dyspnea, and it is gradually progressive over a period of time. And the chest pain, according to history, looks like typical inguinal pain due to ischemia, because it is exacerbated by exertion and relieved by rest. And the palpitations which are occurring are likely volume overload type of palpitations, because they have gradual onset, gradual offset, they are regular, and they are exertional, sir.
So, can it be just sinus tachycardia, which is leading to those palpitations?
It is possible, sir.
So, it is possible. So, why unnecessarily bring in something which might not be
Yes, sir.
a possibility? Okay. So, based on this, what would be your possibilities or differential diagnosis?
So because the patient had onset of dyspnea first for the past 2.5 years, and also associated with 2 episodes of PND, and considering the high incidence of rheumatic heart disease in our country, first possibility I would like to keep of valvular heart disease involving the mitral valve, likely stenotic lesion. And however, there is some palpitations also there, which could be due to sinus tachycardia per se, but if the palpitations are volume overload and significant, then it could be possibility of mixed stenotic or valvular lesion.
Which regurgitation? If you are thinking of regurgitant lesion, which regurgitant lesion?
Sir, mitral regurgitation or aortic regurgitation. By incidence, mitral regurgitation is more common with MS as compared to
But what is the most common symptom of mitral regurgitation?
fatigue, exertional fatigue.
That
the
is
most-
not there.
That is not there. So,
So,
yes,
if at all,
likely
if there
to-
is aortic regurgitation,
yes, sir.
so why would it increase on exertion? What is the exercise physiology? What will happen to the heart rate when one exercises?
Heart rate increases, sir.
Heart rate increases. So what will happen to the end diastolic volume?
So ideally it should decrease, because the end diastolic, the heart rate increases, and there's the diastolic filling period is lesser, so the AR decreases. Also with exercise, the systemic vascular resistance also decreases, so the AR murmur should decrease.
So then why the patient will have volume overload type on exercise with aortic regurgitation? Is it not?
Yes, sir.
So more common is
MR.
rest palpitations or palpitations on left lateral decubitus position.
Yes.
So angina and shortness of breath, single lesion, aortic regurgitation, can it explain both?
So shortness of breath by aortic regurgitation alone would be a very late feature, and angina in AR is largely nocturnal. So AR the presence of dyspnea is potenza. The disease has been there for a long time, and it's a relatively late symptom.
Your second differential is peripartum cardiomyopathy. Is it?
Sir, the point against peripartum cardiomyopathy, the dyspnea exacerbated in the second trimester. It had been peripartum cardiomyopathy. It was more likely to be there in the last trimester of pregnancy, sir. And it could be peripartum cardiomyopathy with residual LV dysfunction because she has persistent symptoms for a long time.
There are two pregnancies three pregnancies, no?
Yes.
They were very close.
Yes,
Does
sir.
the pregnancy has anything to do with the worsening of the symptoms? Because the first two pregnancies were uneventful and
Yes, sir. That is a little unusual, sir. But the first pregnancy was 5 years, and then it was 4 years ago. Then it was 2 years ago. So possibly the lesion has progressed, sir. But that is a little unusual that the first two pregnancies were apparently uneventful, sir.
so this angina you attribute to what? Aortic valve stenosis or
Sir, aortic valve stenosis more likely, or it could be due to RVH and pulmonary artery hypertension by pure MS per se also. That could also cause angina.
and this palpitation, is it a regular or an irregular?
Regular
A
palpitation.
regular palpitation. So you don't consider atrial fibrillation because it is regular.
So she has described very regular and gradual onset and offset, so less likely to be due to atrial fibrillation.
Okay. So without bringing in a valvular regurgitation lesion, can you explain with any existing lesion with pulmonary hypertension, can it produce palpitations?
Pulmonary hypertension, sir, palpitations is generally unusual. There is pain or there is syncope is there. If TR occurs because secondary to pulmonary hypertension, then patient can have palpitations.
Can it be the PND? Can it be the pregnancy itself causes? You are giving PND, so you want to bring in mitral inflow obstruction, or you are explaining with aortic valve disease only?
Actually,
PND?
sir, the PND episodes occurred 6 months ago after the pregnancy. So, likely due to valvular stenotic lesion only, sir.
Valvular stenotic. So you are thinking two valves has been involved.
If we consider angina due to the RVH and the pulmonary artery hypertension, it can be purely because of mitral stenosis also, because then the patient would have exertional dyspnea for a period of time, then and onset of angina later on after almost 2 years of
So she is 28.
28 years.
24 she had one pregnancy.
23 years.
23. So can mitral stenosis progress so fast that within 2 years they become class 3?
So if there is associated anemia because she has been having recurrent pregnancies in succession, it could be because of associated anemia or onset of atrial fibrillation. Generally, the progression of MS takes a longer protracted course. Generally, not so fast.
Does angina of coronary artery disease or aortic stenosis same? You said it's exertional suspension. Does it same? Mechanism is same?
Sir, for aortic stenosis, the mechanism of angina involves both increased demand due to the hypertrophy, due to prolonged ejection time, and the increased stroke volume, increased systolic blood pressure, as well as decreased coronary supply because of the decreased capillary density.
Systolic blood pressure will increase in aortic stenosis.
No, LV systolic pressure will increase. So because of hypertrophy and
Decreased supply. Why?
because the coronary microcirculations are because of the hypertrophy,
No.
it's decreased.
So mechanism is same, and coronary artery disease, angina, and aortic stenosis.
It's a supply and demand mismatch. That last thing of angina is similar.
Okay. And the last thing is there is some other disease that happens in young females during pregnancy, some coronary dissections, because you have got LV dysfunction, you have got angina.
Yes, sir.
So we have got spontaneous dissections.
Sponge CAD. Yes, sir.
So have you? Your DD doesn't mention. Can you show the DD slide?
Can we have the slides, please?
I think it's already open. I just will have to select it.
Because you said HCM will present as PND.
HCM would not present as PND.
One of your differential is hypertrophic cardiomyopathy.
Very lower down the list, sir.
Say bicuspid aorta as presenting as PND. Wow, how come a bicuspid aorta presents as PND?
So very lower down the list.
So when a bicuspid aortic valve will present with PND?
When patient develops LV dysfunction,
Severe LV dysfunction,
severe
but
LV.
you don't have any
No.
anything of severe LV
Yes, sir.
dysfunction. No other disease will in a 24 year, 26 years, nothing like coaptation, nothing like
So bicuspid aortic valve associated with
BSDAR or nothing like that, which can be explained with a single disease. Because other diseases are very
unlikely.
One should always keep Takasu in this age group.
Takayasu,
Yeah.
coaptation, AR.
You should also keep diseases which are more common in women. You have completely included osteoarthritis. Why have you not kept? It's a remote possibility, pulmonary hypertension.
This is group.
This age group,
Young
fellows coming. You should not turn a blind eye to that.
Epstein's can present, sir, with palpitations and but the palpitations are. It can be Epstein's, sir, palpitation.
But what is the symptom which is against an Epstein?
Exacerbation during pregnancy.
No. One symptom which is
Angina.
No. Cardiac output में क्या है? Instincts में? One symptom that is typical of Epstein.
Right heart failure is not there, sir. No.
Very rare, very late, very rare.
So, Abhinav, which lesions are better tolerated in pregnancy? Stenotic lesions or regurgitant?
So regurgitant lesions are better tolerated as compared to stenotic lesions, sir.
And in stenosis, which is better, AS or MS?
Sir, there is a decrease in vascular resistance because of which regurgitant lesions in fact tend to improve during pregnancy. And HCM can also, sir, it can also improve because of the increased volume loading, the increased volume. HCM can.
The question is, out of the stenotic lesions, MS and AS,
which
which
one
is
will be
better
tolerated?
tolerated in pregnancy?
AS is relatively better tolerated.
AS better tolerated in pregnancy.
What are the absolute contraindications to pregnancy?
Severe AS.
Okay.
And severe.
Better tolerated. Yes.
Complete the list.
Absolute contraindications are severe AS, severe MS, severe LV dysfunction, EF less than 30%, and severe pulmonary artery hypertension. These are
coarctation.
PPCM with residual dysfunction, Marfan syndrome with aortic root dilatation more than 45, and bicuspid aortic valve with dilatation more than 50.
Coarctation, is it?
Severe coarctation.
Or CCSDs, saturation agar medically managed CCSDs.
They are, sir, the 3. It's not like the WHO classification of pregnancy. It's 3, not 4, sir.
So one thing is that your disease was progressing very fast. So did you take a very proper history of recurrence of rheumatic fever? Did you take?
I did, sir. But
What are the things you asked? That silently did not say that I had long fever, I had long arthritis. But what are the particular question you asked to rule out a recurrence of rheumatic fever? Because this case looks, she must have had recurrence in between pregnancies, so that's why valve must have progressed so fast. So what are the things that you asked?
sir, history of recurrent sore throat.
How long sore throat fever lasts?
More than a week.
More than a week fever. Any other you asked?
Any history of fleeting joint pain or skin rashes requiring hospitalization for the relief of symptoms, sir?
Have you ever seen skin rashes in any rheumatology?
No, sir.
We asked for chorea type of abnormal movement. That's one thing that without fever, without anything.
Yes, sir, that is
And-
one.
So those are the things important. Okay,
Okay, we'll go to the physical examination.
go to exam.
Sir, on general physical examination, the patient was conscious, cooperative, and well oriented to time, place, and person. She had a height of 155 centimeter, weight of 48 kg, and a BMI of 20 kg per meter square. She is afebrile. The pulse was 77 per minute, regular rhythm, low volume, slow rising, and delayed peaking pulse with no radioradial or radiofemoral delay, and all peripheral pulses were palpable. The blood pressure in the right upper limb was 92 by 60 mmHg. In the right lower limb, it was 116 by 80 mmHg. The respiratory rate was 14 per minute regular, thoraco-abdominal with no use of accessory muscles of respiration, and SpO2 was 98% on room air.
Go back to general examination. Also, you mentioned JVP.
Low volume. 140 by 76.
So yeah, here. But here the problem I found is that your diastolic pressure in upper limb and lower is different. Is it possible in a human being to have difference of 20 millimeter difference in diastolic pressure?
No.
No, ना? In generally 2 to 4 millimeter की range में ही
Yes, sir.
difference हो सकता है, उससे ऊपर नहीं होता.
Yes.
So that point you have written wrongly.
reason for increased diastolic pressure in lower limb in your case? How can you explain?
Sir, it could be because of associated AR. It could be because of the cuff size used.
Most likely it's because of the wrong cuff.
Cuff size.
The same cuff.
There should be more diastolic function.
Yes.
Okay.
The GVP was normal in height, waveform, respiratory variation, and the abdominojugular reflex was negative. Coming to the cardiovascular examination, on inspection, the precordium was normal in shape, chest was bilaterally symmetrical, and trachea was central. Apex was in the left fifth intercostal space, just medial to the midclavicular line. There were no other visible pulsations or scars, and the back and spine examination were within normal limits.
You said patient is in class 3, right now?
Sorry, sir.
Class
Patient
3.
is in class 3.
Sir, for the past 6 months, after she was prescribed some diuretics and the benzathine penicillin, symptoms have improved, and she is now in class 2.
What was the
Good
worst
treatment.
class she was in?
3, sir, class 3.
So what is PND?
PND is class 3 dyspnea, sir.
But it is occurring at rest.
Sir, if orthopnea is there, then it's class 4.
So this is one of the limitations of NYHA class.
Yes.
So what are the limitations of NYHA class? Other limitations? One is
Orthopnea and PND are not considered, and it's subjective.
So, is syncope included?
No, syncope is not included as well.
Again, you
Diagnosis
assume.
is included.
No, sir.
So those are all limitations which you must know.
Again, we assume. No,
Yes, sir.
you assume beginning, at the beginning of history itself, you assume that he already has a disease.
Yes, sir.
So if you assume and if you say that he is NYHA, you already take into consideration that he has an organic disease.
Yes.
So anemia per se cannot be a diagnosis.
Diagnosis.
So it has to be an addition to the diagnosis.
Yes.
Okay. So again, that is one of the limitations of.
NYHA.
There is no objectivity.
Yes.
Say,
It's a very subjective.
you JVP is one of the bread and butter of rheumatic heart disease, but you did not say about the waveforms.
Sir, there was no. It was no 3 centimeter.
JVP is normal. Pressure is raised or normal or low. You said jugular venous pressure is normal.
Normal in height,
Hepatojugular
waveform,
reflex
and
is negative. Jugular venous pulse क्या है? What is the waveforms?
Sir, I could not actually appreciate.
That's
where-
why you have to make it 30 degree.
How do you do that? If you can't
We are insisting you must see the wave.
if we cannot, then we have to make the patient lie supine, and then
You
we
have
can
to see the
Still
waves.
you are not able to see.
even the Trendelenburg, reverse Trendelenburg.
So wave have to be same. ना
Yeah.
वहाँ से आपको काफी information मिलेगा whether it is right sided disease, left sided disease, ASD. So आपने बताया नहीं.
Were you expecting a positive hepatojugular reflex when you didn't find a raised JVP?
Yes, sir.
So why it is negative?
Probably because of diuretics and the symptoms have settled. Because of that, it's negative. Because I was expecting a positive abdominal.
So what is the best correlate, hemodynamic correlate of a positive apotogenetic reflex?
PCWP, sir? Increased
PCWP of how much?
15.
At least 15.
At least 15.
So you are expecting that the patient has a PVH?
Yes, sir.
Because you're
At
going
least
to
moderate.
Moderate, at least moderate.
At least
PVH.
moderate because PND over आता है intermittently. So moderate means how much?
18 to
19 to
19 to 24.
So you are expecting a positive apotogenetic reflex. When is it absent?
If it is PCWP is
No, it is absent. Apotogenetic reflex is absent. One is
obstruction,
positive, negative, and absent.
something compressing the jugulars. So because of which the SVC obstruction.
SVC?
Sorry, SVC.
SVC?
Sorry.
How do you do jugular, hepatojugular reflex?
We give compression on the. Sorry, sir.
Where?
Abdomen, anywhere on the abdomen, and the pressure will be transmitted, and we give a sustained pressure, and the GVP is normally also supposed to rise, and after releasing the pressure, if the rise persists for more than 15 seconds, then we call it a positive reflex. So if there is if for some reason, sir, the pressure is not transmitted,
So why when it is not transmitted? That is the question.
Obstruction, IVC will be obstructed if IVC is obstructed for any reason, sir. But yeah.
So you should say that I'll palpate the abdomen, non-tender area of abdomen will be pressed because you may press over a tender liver.
Yes.
So that is should be your first sentence. Okay, go ahead.
Sir, on palpation, the apex was in the 5th left intercostal space, just medial to the mid-clavicular line. It was localized and tapping type of apex, and there was a systolic thrill palpable in the right second intercostal space. There was palpable P2 and grade 2 parasternal heave. There were no other palpable pulsations which were felt.
Are you happy with that? Your presentation? Happy with the findings? What was your pulse like?
Low volume. I was expecting a heaving.
No. Low volume?
Low volume, slow rising and.
Slow rising. Slow rising means what?
Parvus means that AS is there, severe.
No. What do you physiologically? What does it mean?
Taking
delayed injection.
So
prolonged ejection.
Yeah, prolonged ejection time. So prolonged ejection time, you should always look for only two things. One is the apex has to be
heaving.
Then comes your second heart sound.
Then comes your apicocarotid delay. तीन चीजें बताना होता है.
Yes.
तो आपने तो tapping बोल दिया तो finding का
Actually,
तो
probably sir, MS is, but yes, it should be. It might.
चलो.
Is it possible? Do you think this thing is inaccuracy?
In judgment.
Your examination.
Inaccuracy in judgment.
Yeah, because how you define heaving apex?
Sir, apex is.
And how you define tapping apex? That is the judgmental thing, na?
Yes, sir.
So how you define?
Sir, heaving apex is forceful and it is sustained, sir.
How much?
More than half of the systole, sir.
More than half of the systole is sustained.
Yes, sir.
Okay.
Or in some places it is 2/3 of the systole also.
Yes.
Sir. Somewhere it's
60%, yes.
Yes.
So not half. So even hyperdynamic is half. So
Yes.
more than 2/3. And tapping? What do you mean by tapping apex?
Less than 1/3.
No. Normal apex is defined as a gentle tap.
Gentle tap.
And how that is different from your tapping apex? Got the question?
Yes, sir. Got the question.
One is a gentle tap, which is a normal one, and the tapping apex of mitral stenosis, which is what you are thinking of. How does it differ?
Let's go for it. Because
So,
otherwise we'll run out of
for tap, it is said that just touches
Just
the
touches
apex.
and
Na?
goes.
In tapping, it is said it is a touch and go. In tapping, it is said that it is the accentuated pulsar sound that produces a vibration. That is tapping apex. Go ahead.
On percussion, liver dullness is in right fifth intercostal space. Liver span is normal. Left heart border corresponds to apex, and right heart border is substernal. Left second intercostal space is dull. On auscultation, the S1 was loud. The S2 had soft A2 with the loud P2 with paradoxical splitting, which I felt. And there was a high pitch, sharp opening snap with a narrow A2 OS gap. And there were 3 murmurs. The first murmur was a mid diastolic.
Okay, what do you understand with this narrow A2 interval? Suggesting severity of mitral.
Yes, sir.
So your A2 is getting delayed because of paradoxical split. So does it have any significance now?
No.
Paradoxical split
Yes.
is because A2 is getting delayed.
Yes. So it has no
And it
significance.
is going more towards worse.
So that will be narrow even if the MS is not severe.
So it not that it is not severe.
Yeah.
It might not help in judging that this is severe.
Yes. On auscultation, sir, there were 3 murmurs. There was a mid-diastolic murmur of grade 3/4, heard best at the apex, non-radiating, low-pitched, rumbling mid-diastolic murmur with pre-systolic accentuation. Best heard with the bell of the stethoscope in left lateral position, increased on expiration and decreased on inspiration and standing. There was another ejection systolic murmur of
What
grade.
is length of the murmur? Mid-diastolic murmur, what is the length?
Sir, it's a marker of severity of the murmur for how long.
In your case, what is the length? MDM length?
Short murmur or a long murmur, or what is your patient?
That's long with
Yes,
Yes,
sir.
describe it. Long means what is long for you, maybe it is not long for me. So is there something that you can describe it to? Can you relate it to something?
Before the systole,
Some event, now you have to relate it to something. Either you say related to a proportion of diastole or related to some other sound.
A2,
A2 is the issue.
A2, मतलब OS, it begins with the OS, so narrow gap, so it begins with the OS. So
Start, either you say it related to the OS, or if you can't hear an OS, related to the length of diastole. Whenever you say anything, it has to be in relation to some other event in that cycle. You just can't say, oh, long, short, early, mid. Yes,
So what Dr. Sami is asking is, if you have got a MDM and pre-systolic you have, if it is continuous, it would be a long murmur, no? 2/3 of the diastole would be occupying them. So it's a long. If you have got a gap in between, so it would mean that there may not be a tight mitral stenosis. So you cannot say that as a long murmur. There will be 2 separate events. Okay.
That's all about the mid diastolic murmur. Is there anything that is missing? Which is the PSA.
Go to second one. My second murmur.
the second murmur was an ejection systolic murmur of grade 4/6, best heard in the right second intercostal space, radiating to both carotids. It was a harsh murmur with a crescendo-decrescendo configuration. It was a long and delayed peaking murmur, best heard with the diaphragm of the stethoscope during expiration and decreased on standing and sustained hand grip. And it was associated with appreciable
Bolo, appreciable.
apocarotid delay, but I
Okay.
should have said that.
Yeah,
Earlier.
examination.
Yes.
Yeah, okay.
And the third murmur was an early diastolic murmur. Sorry, sir.
How do you do a hand grip, sustained hand grip?
Sir, I asked the patient to squeeze my finger and continue to.
Is there any other standardized?
Standard is Bolo now.
How should you do a hand grip?
And what should be avoided?
Valsalva should not be done because the patient might also.
Breath holding should be avoided. Your answer should be breath holding
hold.
should be avoided. You should be asked to take normal breath. Valsalva thodi
How
bolo.
to do a hand grip? See, if you mention a hand grip, you have to know how to correctly do it. Batao? You're supposed to take a sphygmomanometer
And-
and plate it. Then what? बोलो आपको पता तो है क्या करोगे?
Whole mercury
You
yet?
have to,
maintain the pressure, na?
At
Maintain
about
the pressure
40,
up till 40.
up till 40.
That is sustained hand grip.
मिलेगा नहीं सिग्मोमैनोमीटर whatever. पता होना चाहिए.
Okay.
What happened to your metaslic murmur on sustained hand grip?
Increase.
What would was it expected to increase?
You are not
Yes, sir.
hand grip.
Yes, sir.
You're not mentioning what happened to your metaslic murmur on hand grip. What is expected? What happened then? And the mechanics.
Increased.
माइट्रल स्टेनोसिस मामला इंक्रीज होगा
Actually, I
अगर
started
आपका
to-
वो नहीं होगा तो
It should decrease. मतलब the stenotic AS murmur will decrease.
unless it causes tachycardia, why should it increase? What is the mechanism increasing?
You didn't mention.
Yes, sir.
डिक्रीज का क्या मैकेनिज्म है? इंक्रीज तो मैंने मना कर दिया क्योंकि अगर हार्ट रेट बढ़ेगा तभी तो इंक्रीज होगा, ग्रेडियंट बढ़ेगा, डिक्रीज हो सकता है.
Hand grip say what happens physiologically?
The afterload increases.
Afterload increase.
So-
What will happen to the blood pressure and pulse rate?
The blood pressure will increase.
And pulse rate,
Pulse rate will
either it remains same or it comes down.
down.
So either there is no change or it has to come down. So it will not increase.
even with afterload increase, there will be gradient will decrease.
It is like in AS also.
So it has to come down. So that was the
Because one
question
of your
asked.
diastolic murmurs is increasing.
Yes, sir.
And another you didn't mention.
AR murmur is increasing. Yes.
Okay, go ahead with the third murmur.
The third murmur is a early diastolic murmur, grade 2/4 decrescendo in left third intercostal space. High pitched, soft blowing, best heard in the sitting up and leaning forward position with the diaphragm of the stethoscope and breath held in expiration and increased only on sustained hand grip. I could appreciate this only after hand grip.
But you did not do hand grip properly.
Yes.
There is a hand grip meter,
Yes.
but it's not available in our clinics. So you have to do it a sphygmomanometer. Okay.
Time out. Go back. You didn't find. You have a severe aortic stenosis.
Yes.
You didn't find an S4.
No, sir.
Expected, not expected.
Expected, but MS, in the presence of MS, S4 might not be there, sir. Probably I missed it, or even MS can cause the absence of.
No, your answer again wrong. Mild MS होगा तो, so you should say that significant MS will not allow us to.
So this is not an MS. According to your description, this is a severe MS. You take out the aortic valve, put in a normal aortic valve, and this MS will be severe. Because in your description it is severe MS, and increased LVDP because of aortic stenosis and aortic regurgitation, your murmur is getting obtended.
Yes.
So despite obtendation,
You
if
are
it is
getting-
severe, you put in a normal valve, it will be so much more.
It is
severe.
actually very, matlab, we are underestimating.
So is it possible you are having a young patient who had a history of 3 pregnancy with normal vaginal delivery, and you are saying that patient have double stenotic valvular? Is it possible? It's very unlikely.
Very unlikely.
Severe AS, severe MS. Is it possible? मतलब
Very unusual. It is very rare. The combination
And
itself per se-
she had uneventful pregnancy.
and severe ASMS per se, the combination is also very relatively rare.
तो इसी पे बताओ what are the percentages of MS, MR, AS, AR, TSTR in rheumatic heart disease कितने percentages क्या combination है?
So most common combination is MS with MR. It is around 46%. Then we have MS with AR. It is around 26%. Then we have MR with AR, around 22%. Then comes this combination of MS with AS of around 2.4 or 2%, around 2%. Then we have a relatively rare combination of AS with MR, which is around 0.9%. And very rare is AS with AR.
And tricuspid valve disease.
Tricuspid valve disease is largely secondary.
primary tricuspid
Primary-
valve,
Primary
organic.
tricuspid valve disease, how many percentages will happen? TS, how many will have TR? Organic.
I'm not sure.
What is the autopsy rate?
On autopsy, it is found to be more.
How much?
I'm not sure, around 15%, I think, is clinical. 15.
40, 50%.
That is clinical. Pure PS alone, organic PSTR is only about 4-5. And you have to know the sources. कहाँ से quote कर रहे हैं आपको पता होना चाहिए. I think you have to come to the clinical diagnosis.
Diagnosis.
So the final diagnosis: valvular heart disease, rheumatic etiology, severe MS, severe AS, mild AR, moderate PVH, mild to moderate PH, normal sinus rhythm, and normal LV function. Currently in NYHA class 2, with no features of heart failure, acute rheumatic fever, or infective endocarditis.
As we are saying that this is not tenable diagnosis, something has to be moderate because your AS should have been moderate. That is the thing that you are missing.
Probably
because your apex is not at all
heaving.
having. You are still saying tapping apex. You are still saying inside 15 mid line. So that is the probably, if I can see that is the error you have done. Last thing, you have not mentioned recurrence of rheumatic fever. That's a point that only fits in your diagnosis. She must have had a recurrence and you missed in diagnosis. Otherwise, so fast progression of these two diseases is not possible. Metastenosis must have progressed because of a second, if it's a, बताना चाहिए था इस case में. Otherwise, cannot explain a short history, so much of progression.
Again, normal LV function, your explanation is not right. No S3, you are expecting an S3 in this?
In severe MS, you have written, and now you are writing S3.
So you can just say.
Same way you have, what you have written before he mentioned, same way when there is severe aortic valve disease, A2S gap is not mentioned because in AS, your aortic sound will be very soft, so you may not be able to hear. In AR, aortic sound is muffled, so you may not be able to hear. In hypertension, in hypotension, all these things, A2S gap is sometimes, so same way hypertension, but you don't have hypertension in this case.
So what you have heard cross check because आपका तो सब कुछ ही severe है तो आपका pH mild है PVH moderate है patient class 3 तक पहुंच गया तो कहीं ना कहीं कुछ आप मिस कर रहे हैं या कहीं कुछ गड़बड़ है.
And there are too many diastolic sounds you have heard A2 P2 reversed loud P2 opening snap. So
yes.
I think let's see the ECG extra.
Last minute.
So to improve your diagnosis, maybe you can just say stage D, valvular heart disease. So the new classification which has come, you can just say clinical staging.
This is right axis deviation, and the P wave is broad.
LVH, no LVH.
No LVH. Actually, there's overlap in this, but AVL, no evidence of LVH here.
V5 ka R you are not able to discern it
yes, sir.
properly. So this is half standardization.
So यहाँ से देखो
LVH is there.
There is an LVH.
There is LVH. Yes,
you half standardized ना.
Yes, sir. There is LVH. This is half standardized.
So your tapping apex is now in suspicion.
It should have been heaving. It was heaving.
That's fine. That's okay. You can commit errors. There is no problem. What else?
Axis is right axis, sir.
Right axis.
RV forces are also.
RV forces.
So what about V1? See V1.
V1 has a positive R wave.
RVH
but RS ratio is less than 1. No?
Less than.
Lead 3 में P wave. You have not mentioned positive findings.
There is also bifid broad P wave.
Positive findings.
Suggestive of LA enlargement.
Yeah.
So LA enlargement, LVH, RV forces also dominant in the form of positive R wave in V1 and right axis deviation.
Yes.
What does U wave suggest? There is a significant U wave.
U waves in chest leads.
Precordial leads.
Hypokalemia.
Hypokalemia, but there is no changes in ST.
No STT.
The hypokalemia starts with ST deviation
Yes,
and then U wave. So what does the presence of U wave suggest? Does it tell you about some valvular involvement? In valvular heart disease, what is the lesion which is most commonly associated with U waves? Aortic valve disease. Aortic valve disease. So again, that is an indirect evidence that aortic stenosis or aortic lesion should be there.
Okay, X-ray.
Just go back. Half.
Half standardization. Minus. Yeah.
This is full. Next. Hold. So where is the right axis deviation now?
Most likely because of half standardization.
No.
Position.
Go back.
Oh, no, sir. Deep reversal is not there.
Yeah, it's not.
The next job, but still there is a deep S in AVL. So probably there is some amount of right axis deviation.
Show the X-ray. Quickly positive finding बता दो.
There's no cardiomegaly. There is evidence of LA enlargement in the form of straightening of left heart border, and double atrial shadow is also there. And there is cephalization suggestive of PVH.
How much?
Grade 1 PVH.
So you say that percutaneous hypertension is grade 1? Yes.
No, grade
Carly's lines you can bring, na?
Grade 2 PVH is there.
Actually, if you look at it carefully, you will find that there is an interlobar fissure also which is prominent.
Yes.
Right side? There, just before. No.
थोड़ा ऊपर
R के पास देखो, R के पास. Yeah.
R से थोड़ा नीचे बिल्कुल हाँ this is
So quickly tell us the classification of PVH on X-ray and the values.
This Larry Elliott, the classification, Larry Elliott classification of PVH. So grade 1 is cephalization. It occurs at 13 to 18. Grade 2 is 18 to 24.
19 to 24.
19 to 24.
क्या finding है?
Yes, sir.
Findings क्या है X-ray में? वो पूछ रहा हूँ.
Grade.
Normally which veins are prominent, lower lobe or upper lobe? Normally lower lobe. Then first what happens? The upper lobe veins become equalization. Then first occurs equalization, then cephalization, then goes into the other stages. Okay.
What is the apex like?
RV? LV.
LV. The angle is obtuse.
Can it be inside mid-clavicular line? This apex?
Slightly out.
Okay. Go to echo.
Do you think there is a LA he said. LA he said. Is there any significant regurgitation lesion? You said regurgitation lesion is also possible. With this X-ray, any significant regurgitation is possible.
Any change in your diagnosis based on ECG X-ray? Any change? AS कहाँ गया?
AS गायब.
AS तो है ही नहीं. हमने चेंज करना है कुछ, MS को बढ़ाना है घटाना है, AS को हटाना है, कुछ करना है.
MS को बढ़ाना है, AS को कम
कर दिया जा रहा है. इको देखो. ECG में लिया जा रहा है, कैसे तुम लोग ऐसे हटा सकते?
X-ray
ऐसी बात सुन लिया करो.
चलो इको पे आया.
Let's see the echo now. First.
Come back to the echo and we'll see. Okay, so see there MS.
बोलते जाओ.
This is parasternal long axis view suggestive of AML doming with PML fixed with thickened mitral as well as aortic valve and doming of the.
So in this view, it is severe or no severe? Not severe.
LVH is quite.
AS is severe or no?
AS is severe because they're doming.
No, darling, there is no LVH.
valve is
LVH
opening.
is this.
And
LVH कहाँ है?
Opening of valve is.
Valve is opening so well. There is doming, no doubt, but not severe.
Yes, LVH is also not.
You can say I can't come. You want to see the seat.
हाँ gradient देख लो. Go ahead.
Okay, forward. Next. But खुल रहा है अच्छा.
अच्छा खुल रहा है.
खुल तो अच्छा है. आगे देखो.
Yeah. Some bit. Okay. You must also be prepared with an answer when you have got AR that why was it not Austin Flint murmur? Those are very standard questions which they ask. So be prepared with those answers.
बोलो.
Sir, short axis view of the mitral valve and papillary vessel level suggestive of normal LV function and
pH, no pH.
Slight D-shaped cavity.
Significantly
Looks like a
D-shaped.
D-shaped cavity.
Significantly D-shaped. Next.
The mitral valve area by planimetry is 0.65, and on continuous wave Doppler across the mitral valve mean gradient of 15 with mitral valve area by pressure half time of 0.8.
Why is this discrepancy there?
Because of the increased LVEDP
Very good.
by
Because of aortic heart disease.
aortic valve disease.
In mitral planimetry, which time we should see in a cardiac cycle?
Diastole.
Which diastole? Diastole is a long time. When it will be maximally, volume will go maximum in sinus rhythm.
The planimetry of mitral valve.
Diastole has 4 phases, no?
Yes, sir.
So which one is the one?
What are
which
the
is-
phases of diastole?
Isovolumic relaxation,
One.
then rapid filling phase,
Mhm.
then the
Protodiastasis. Protodiastasis,
Diastasis.
then atrial contraction.
atrial contraction.
तो कुछ टाइम में सबसे ज्यादा mitral
Atrial
valve
contraction.
तो आपका सिग्नल कहाँ है? अर्लीस्ट डायस्टोल में है आपका, है ना?
Yes,
कहाँ होना चाहिए?
कहाँ होना चाहिए था?
P wave के.
P wave के।
तो फिर
फिर
इसमें
आपने
थोड़ा सा
गलत
ज़्यादा
टाइम पे
over
एग्जामिन
estimate.
किया. ओके.
Peak of R. Peak of R is end diastolic mechanical and start of systolic electrical. There is always a delay.
Okay, go ahead.
This is the M mode across the in the plaques view at the tip of the mitral leaflet, suggestive of
Finish in 1 minute. जल्दी से finish
Next,
करो.
next.
Next case
Normal
is
elevation
सब wait करो.
Next. Just show me the gradients across the aortic valve and then we'll finish.
हाँ, yeah.
Velocities across.
Because it's never going to
So
finish.
pH is severe. pH is severe.
yes.
This is severe pulmonary artery
Yeah.
hypertension. Next. Next.
To show us a gradient here.
Gradient.
Go next. It's a bread and butter equivalence.
Look at the aortic valve, it is opening so well. Saw the short axis?
Yes, sir.
Next.
नहीं वो ज़्यादा नहीं करना.
Moderate.
Delayed peaking नहीं है, early peaking, moderate.
Ugly. Peaking is ugly.
It's not circular dense. It's early
चलो
peaking
आप
triangular
बताओ
shape.
करोगे क्या?
Yes, is not that severe.
क्या करना है?
Severe MS with severe AS.
28-year-old female. कितने बच्चे?
3 kids.
3 kids.
Three
बताओ
kids
क्या?
or 4 kids?
3 kids.
काफी है. क्या करना है?
Double valve replacement.
क्यों? MR ज़्यादा है?
Alternate.
MR ज़्यादा है?
Alternate is PTMC will but aortic valve disease is significant.
So once you do PTMC, what will happen to the aortic valve severity?
It will increase the severity of.
No, your answer is wrong because a mitral valve should be tried to open. So OMC you should say. Double valve replacement mortality is very high.
OMC with
AVR.
AVR.
That would have been your first answer. If it's definitely very deformed valve, very much calcified, very much caudal shortening, and you have got MR mode, then your answer is correct. But
MR is not there.
here is nothing is there. Young female OMC plus AVR करने में क्या problem आ रहा था? You could say करेगा तो DVR ही surgeon, but you should say.
Until unless the rhythm is in atrial fibrillation,
Yeah.
where you need a good amount of anticoagulation.
Then we
Still in India, so much of start valve.
Money is no criteria for that.
Approach to chest.
What valves will you give?
I think we'll stop.
Okay. Chalo.
Natalie?
Okay, good case.
Thank you, examiners. I would like to extend my heartfelt gratitude to the examiners and the presenter in today's session. Your active engagement, insightful questions, and willingness to learn by students have made this session truly valuable. I will be switching to the second half of this session, that is X-rays in rheumatic heart disease. We have Dr. Neeraj Nirmal Pandey, Assistant Professor of Cardiology of Department of Cardioradiology. He'll be taking this session.
Thank you. So, this will be a brief approach to examining or reading the X-rays in patients with rheumatic heart disease. I do not have any disclosures related to the presentation. And over the next 30 minutes, I will try to briefly introduce the subject. It's some of you may be of the opinion that this topic is not of much relevance today. Learning about radiographs when you can easily access, you have easy accessibility to an echocardiography and even higher or better modalities. But there are some benefits, and it's always good to know how to look for and what to look for when you come across a radiograph in any cardiac patient. I'll also be briefly discussing the normal cardiac borders. What are the expected findings when a particular chamber enlarges, and briefly about the pulmonary vascularity. And then we will delve into radiographs in rheumatic heart disease. So, rheumatic heart disease, we all know it's a disease of the low socioeconomic society, especially in the sub-Saharan Africa and Southeast Asia. Even today, in endemic territories like India or in African nations, the prevalence is quite high. And even the numbers which are presented in various studies may be underreported because these are mainly from hospital generated data. They are not actually community numbers. So when we come across a chest x-ray, we should first identify the heart borders. The right heart border essentially is comprised of two parts. The upper half is formed by the superior vena cava and the lower half is formed by the right atrium. On the left side, it is formed of four parts actually. The cranial most part is the aortic knuckle. Below the second bump is the mic was not on. No. Okay. So the second bump is the pulmonary trunk. Below that, we may see a slight convexity. Sometimes you might see a slight bump. It's the third mogul, which is formed by the left atrial appendage. And below that, the entire heart border is formed by the LV. You should note here that the left atrium does not form any of the cardiac borders. And even the RV, if you just consider the right and left heart border, the RV does not form one of them. It just forms the diaphragmatic or the inferior border. So the upper segment is almost vertical. We do not see any bulge. It's formed by the SVC. The lower segment is slightly convex and it is formed by the lateral border of the right atrium. In older individuals, however, your upper border may become convex because the ascending aorta, when it becomes slightly dilated and becomes unfolded, may shift towards the right and form a convex upper right heart border, which is usually straight when it is formed by the SVC. The left heart border, we have already talked about it. So we'll start with the LA. If the LA enlarges, what appearance we should look for in a chest radiograph? The LA normally lies in the midline, does not contribute to any heart border in the frontal projection. And we have, whenever the LA enlarges, we have a few direct signs, a few indirect signs. The first sign is the double density sign. I will be discussing all these findings later in much more detail when we come across the X-rays in CHD. An objective measurement can also be made when we see or we measure from the midpoint of the left main bronchus to the lateral border of this double density. And then we also look for the enlargement of the left atrial appendage. These are the few direct signs. And then you can have indirect signs where, because of the dilatation of the left atrium, the left main bronchus will be superiorly displaced, and subsequently the carina will also get widened and you will find an obtuse or more than 90 degrees carinal angle. The right atrial enlargement, it is directed posteriorly and towards the right, and it will result in elongation of the right cardiac border. And distance between the lateral border of the RA and the midline, it is increased. Just a second. So the distance between the midline and the lateral border becomes increased, and also you can measure this distance of the lateral part of the RA border to the lateral vertebral margin, and we have some values beyond which we will call that the RA is enlarged. LV enlargement, there is a downward, inferior and leftward displacement of the LV apex, and which is associated with rounding of the apex as well. While in RV enlargement, the vector of enlargement is leftward and upwards, which results in uplifting of the cardiac apex, and the heart rotates posteriorly because the RV is an anterior structure. So when it gets enlarged, the heart rotates posteriorly, and along with this uplifting of cardiac apex, we will also see a decreased prominence of the aortic knuckle. Related to the pulmonary vascularity, I will only be talking about pulmonary venous hypertension and pulmonary arterial hypertension because these two things are important in making a diagnosis in a case of rheumatic heart disease. So pulmonary venous hypertension is said to be present when your PCWP is beyond 12 mm of Hg, and progressive pulmonary venous hypertension, it produces changes in the radiograph which will reflect its presence as well as it correlates very well with the severity of pulmonary venous hypertension. It's not the case with PH, but with PVH you can very reliably comment upon the severity of PVH based on your radiograph findings. So the first sign or the first stage of PVH is the cephalization of pulmonary vessels. Whenever the hydrostatic pressure or the PCWP crosses 12, fluid leaks into the interstitium, it compresses the lower lobe vessels first, and then the resting upper lobe vessels, which are normally smaller in caliber in a normal chest radiograph, they are recruited to carry more blood. So first there will be equalization and then cephalization of the pulmonary veins. When this progresses to stage 2, you will see all the interstitial signs when the fluid has leaked into the interstitium. A most prominent sign is the curly B lines, which is thickening of the interlobular septa. They are clearly defined, very thin lines, and they touch the pleural surface and are seen to extend perpendicular to the pleural surface. They are best seen laterally at the costophrenic angles, which is seen in both these examples. I'm sorry. Yeah, sorry for that. So these curly A lines, they are less commonly seen. So curly A lines, they are distinct from the curly B lines. They are less commonly seen and they are longer. They are not seen at the costophrenic angles. They are angulated and you see them crossing the inner 2/3 of the lungs in varying directions, but eventually they are seen pointing medially towards the hilum. Then other features, these are a bit difficult to discern on a chest radiograph, but you should know about it. One is peribronchial cuffing, where the edema collects in the peribronchial interstitial space, and then you see visible bronchial wall thickening. On a normal chest radiograph, the wall of the bronchus is barely discernible, but if you see a thick bronchial wall, it means that there is some fluid in the peribronchial interstitium, and it's a sign of pulmonary venous hypertension. And this is one of the most consistent findings, where you see that the hilum and the pulmonary blood vessels near the hilum, they are appearing indistinct because of edema in the perivascular interstitium near the hilum. So this perihilar haze is the fourth sign. And when the pressures cross 25 mm of Hg, we progress to the third stage of PVH, where you see frank alveolar edema. This edema has a typical central non-gravitational distribution. You will not see that the edema is more distributed towards the bases. It's a non-gravitational distribution, and you see that the lung cortex is free of this edematous fluid, giving rise to a typical bat wing type of appearance. This, what we can see here on both sides. This has already been discussed. And in PH, although the radiographic findings do not correlate very well with the mean pulmonary arterial pressures, but it can reliably point you towards the presence or absence of pulmonary arterial hypertension. So what happens in PH is that the central vessels from the MPA, the main pulmonary artery, up to the second order branching vessels, they dilate, and after that, after the second order branching vessels, all the peripheral lobar vessels, they constrict. So there is enlargement of the PA segment, which is the second mogul in the chest X-ray, and you will see enlargement of the right and left main pulmonary artery. Because of that, the hila enlarges, and this severity of central dilatation is said to have a rough correlation, but not very accurate as seen in case of PVH. Also, the peripheral arteries will be pruned. Normally, you will see that the pulmonary arteries, they have a dichotomous branching and they gradually decrease in caliber, but in cases of PH, you will see pruning where there is a more abrupt decrease in the caliber of the peripheral vessels. There is more than 50% loss of the vessel diameter at any point of branching. So this centrally dilated pulmonary arteries with peripheral pruning is the characteristic sign. of PH. Also, you can see associated cardiomegaly because of the right atrial and RV enlargement, which will occur secondary to PH. So now we come to the topic in hand, which is approach to X-rays in rheumatic heart disease. So this is a brief physiology, pathophysiology. You are better aware of all this. But what I'm interested is in the last slide, and also the prevalences which Anurag gave in his presentation. Mitral valve disease is involved in the majority of cases. So in essence, if you are diagnosing a case of rheumatic heart disease on a chest radiograph, you are essentially trying to look for mitral valve disease. So these are the findings which you should be looking for in a chest X-ray. And because of course mitral valve is involved in the majority of patients, and because of this mitral valve involvement, which can be stenotic more commonly or regurgitant, there will be enlargement of the LA, left atrial appendage, or both LA and LAA. And sometimes you will see that the LAA dilatation is disproportionate to the LA dilatation, and so on and so forth. But again, we come back to those signs of LA enlargement. The first thing is the double density sign. But now that we are looking at it in detail, we should also not confuse it with a normal density of the LA, which is not in fact the density of the LA, but the confluence of the pulmonary veins. They also cast a shadow on a normal chest radiograph. And if you look through or look at over-penetrated films, or if you are working on a workstation and looking at digital radiographs, if you change the window, you may see a density behind the RA. So you have to distinguish this normal density of the pulmonary confluence from an enlarged LA. So the double density which you will attribute to an enlarged left atrium will have increased prominence, by which I mean it will be more inferior, and also the radius of curvature will be increased, so that you know that this double density is not just because of the pulmonary venous confluence, but because of the dilatation of the entire left atrium. But again, some may argue that this double density is a subjective sign. Some may say that it's a double density. Others may disagree. So there is an objective assessment as well, where you measure from the middle of this double density up to the middle of the left main bronchus, and an arbitrary figure of 7 centimeter is given. It has shown to have a very high diagnostic accuracy in diagnosing dilated left atrium. So a distance of more than 7 in women and more than 7.5 in men is said to be quite specific for LA enlargement. In more severe cases, the LA may continue to enlarge, and as you can see in this axial CT image, now the lateral border of the LA has even crossed and extended beyond the right atrium. So in these extreme cases of LA dilatation, sometimes the LA can enlarge so much that it now forms part of the right heart border. Then again, the indirect signs, LA is a posterior structure. It will enlarge, extend superiorly, and elevate the left main bronchus, which will result in opening of the tracheal angle. The carinal angle is usually 50 to 70 degrees. With the splaying and elevation of the left main bronchus, it will cross 90 degrees. Also, this elevation of left main bronchus may also be associated with compression of the left lower lobe bronchus, which will then cause a left lower lobe atelectasis, which may be a supportive finding in your chest radiograph assessment. LA enlargement is very interesting because an enlarged left atrial appendage is characteristic of rheumatic heart disease. You may have enlarged LA from non-rheumatic causes of mitral stenosis. In those cases, you will rarely find that the left atrial appendage is also enlarged. Now, the mechanism of left atrial appendage in rheumatic heart disease is unknown, but there is a suggestion that this left atrial dilatation is not secondary to the hemodynamic effect of the MS, rather it's secondary to the inflammatory response, which is also attractive embryologically because the LAA Left atrial appendage is part of that vestige which forms the left atrium, while a large part of the LA is formed from structures which were separate embryologically, because the posterior wall of the LA is derived from the confluence of the pulmonary veins, the common pulmonary vein, which is then integrated into the LA. So this is attractive embryologically, maybe, but I'm not really sure. And also, this mechanism may actually be true because it does not correlate with the hemodynamic factors. Sometimes the left atrium is enlarged to great extents, but the LA is not enlarged to that extent. So there is a mismatch between the LA and LAA dilatation. Therefore, it's difficult to explain that hemodynamically. Then pulmonary vascularity needs to be looked at. I will be citing examples later why this is very important. So you need to look at presence or absence of PVH. PVH will usually be present whenever MS is there, but you need to look for pulmonary vascularity, increase in pulmonary vascularity, or features of PH, because whenever there will be MS, there will be increased LA pressure, it will cause increase in pulmonary venous pressure, and then there will be a passive development of pulmonary arterial hypertension. This passive PH may be radiologically inapparent. However, when the LA pressure crosses a certain limit, then there is a disproportionate increase in pulmonary arterial pressure, and then you will see these findings of prominent central pulmonary arteries, pruned peripheral arteries, and even enlargement of the RA and LA. Calcification is another important sign. However, because it is very difficult to look or find or reliably diagnose the presence of calcification in an X-ray, absence of calcification is relatively insignificant in ruling out RHD. However, when you see calcification in the mitral valve region, it usually implies rheumatic origin. Also, calcium in the mitral annulus is heavier, larger, it is more easily demonstrable. And sometimes with these dilated left atria and left atrial appendage, the wall can also calcify. The wall of the left atrium, the wall of the left atrial appendage, it is usually associated with presence of thrombus, etc., along the LA wall or within the left atrial appendage. So you can also see calcification which is along the left atrial wall or the left atrial appendage wall. So this was all related to the chest radiograph findings which will be seen in a case where the mitral valve is involved. Now, as was today's case, there was involvement of the aortic valve as well in addition to the mitral valve involvement. So isolated aortic stenosis is rarely seen in rheumatic heart disease. So the primary function, again, when you are reading an X-ray, is to look for mitral valve stenosis only. You have to look for features of mitral valve disease, because if it is a AS of rheumatic origin, more or less it's more likely that the patient will be having some mitral valve disease as well. In terms of aortic regurgitation, again you will have some concomitant mitral valve findings, but findings pertaining to the aortic regurgitation, you will see a volume loaded if there is a concomitant MR is present, then you will see a volume loaded LV with normal pulmonary vasculature, and the aortic knob or the aortic knuckle will be prominent because of the aortic regurgitation. Tricuspid regurgitation is associated with mitral valve disease in many cases, but most commonly it is functional, which is secondary to the development of PH, and then there is RV enlargement, then there is tricuspid regurgitation, which is functional. But if you see a substantial RV enlargement without PA dilatation, so you are suspecting that this RV enlargement or this right-sided pathology is distinct and not passively transmitted from the left-sided disease, those cases it could be an organic TR or related to direct rheumatic involvement of the tricuspid valve. Pulmonary valve involvement again is very rare. Pulmonary regurgitation, if present, it is again more commonly it will be functional because of the presence of pulmonary arterial hypertension, but when present there will be more marked and progressive enlargement of the PA segment, and because of this pulmonary regurgitation, because the PA segment dilates so much, many a times we overestimate the severity of PH because of the prominence of the PA segment. So yes, interpreting chest radiographs in rheumatic heart disease is not very easy. It needs some level of expertise, But yes, it is still important because it is universally available. It is a very cheap modality, very fast acquisition, and can serve as an alternative to portable echocardiography, thus having a potential role in screening of endemic populations in resource poor settings. So we can consider the role of X-ray there. And as always, most of the patients who present to the OPDs, etc., they are carrying a chest radiograph. So you should be aware to look for these findings whenever you are faced with a patient of rheumatic heart disease. Thank you. I'll be happy to take any questions if you have any. Thank you.
Okay, 2 questions. We have 2-3 minutes.
One question is when right motor is formed by LA, how differential is formed by RA?
Yes. So the right atrium, because it is in contact with the diaphragmatic border, the right atrial border is continuous with the diaphragm. But if it is formed by the LA, you will see that the right border curves and then goes medially towards the vertebral border. So then you are sure that it is formed by the LA. And then before it touches the vertebral border, somewhere you will see a right heart border, the border which is formed by the RA, coming and joining the diaphragmatic border.
Anything with sharpness? In kissing, say that LA border is very sharp, RA border is little less sharp in radial because
I'm not really sure. We have this distinction when we differentiate between pulmonary arteries and veins. We say that the pulmonary venous borders are a bit blurry and the pulmonary arterial margins are sharp, but I'm not really sure about RA and LA.
So nowadays you have digital X-rays.
Yes.
So what is the best way to say right atrial enlargement?
Right atrial enlargement. The right atrial enlargement is still looked at by looking at the height of the RA and the rightward shift of the right heart border. So we have few objective criteria which I enumerated in my slides. 5.5 centimeter from the midline or 3 centimeter.
Digital, you can't measure 5.5 now. The digital X-ray.
Okay, but we do have a scale at the side. So with digital X-rays, we have a scale at the side. Even if you zoom in or zoom out, the scale also zooms in and zoom out. So you can make those measurements. And again, sir, the height of the RA, if it is comprising more than half of the right heart border, usually it's an enlarged.
So how many of you know that so-called half height of the right atrium? Can you draw those lines? Because that's not given in textbooks. Can all of you draw those lines? Most of you are blank, no? You want to tell that line again? Describe it.
Okay, you can assume that the upper part of the aortic arch, it forms the first line, and where you see the notch, where the SVC, there is a change in contour at the point where the SVC joins into the RA, and the third point will be the right cardiophrenic angle. So this is the entire distance, half. If this comes up, you will say that it is more than half of the right heart border.
So this
that
is not
implies
described in Ron Waller. So you draw those lines, and if the RA upper border goes above that, then RA. Okay,
Thank you, sir.